Okay, let's do this. So I'm Lauren Meffin, speech pathologist, lymphedema therapist, and we are going through a journey of a 76-year-old patient, right base of tongue primary. That patient had levels involvement of level 2A and level 1B, okay? Now, here we are. We've completed our pre-counseling visit, which is either going to be somewhere around just prior to their mapping, where the patient is undergoing fitting for their head and neck radiation, or it's going to be somewhere around week 1 of their treatment, okay? Week 1 looks like, for me, a lot of counseling, a lot of education, and getting them started on proactive exercises. Now I'm following up with my patients week 3, week 5, week 7, ideally, and then we follow up with them at weeks following treatment 4 through 6. Okay, so they get a break from us. Why do your patients need a break from you? Well, we're speech pathologists. Your patient has just gone through potentially 7 weeks of radiation treatment, and they need to heal. The acute side effects of their radiation need to heal. The tissues need to heal. And honestly, patients, they feel terrible during this time. They're, lethargic. The fatigue has really given them a difficult time. And they've just made it through this chemo and radiation. And the last thing they want to do is come to you. You also can't do a lot of work on these patients. So one of the most important things in understanding the lymphedema therapy, the role of lymphatics, is there's 4 components to this, right? Those 4 components also involve skincare when you're looking at the gold standard for complete decongestive therapy. You cannot overlook skincare, okay? You have to understand that manual therapy cannot be completed on a newly radiated neck, okay? Manual therapy cannot be completed on the insides of the mouth when the oral tissue is healing, when the tongue is resolving. Possibly your patient involved something called mucositis, right? What is mucositis? Mucositis is essentially tissues that have reacted to the treatment of the radiation in a negative way. Some of those tissues look like ulcerations, sores, redness. There may even be areas of white patchy discolorations. But essentially, how does that functionally impact your patient, okay? When my patient has mucositis, what does that look like to me? That looks like a problem swallowing. That looks like me trying to convince them to take the pain medication that their physician has prescribed so that they can swallow. Mucositis is a serious side effect that when it occurs, our patients no longer want to take things and put them in their mouth. Why? It hurts. It hurts miserably. It's very painful. We may see sores that are on the tip of the tongue, the lips, inside, even cheeks, but we may not see the sores that are over the back of the tongue or down into the pharynx, okay? So you really have to encourage your patient to follow the physicians closely and their recommendations, because maybe your patient comes to you, maybe they come to you week 5 of their treatment or week 7, and they come to you during that time and they show you inside the mouth, look, it hurts to open. It hurts for me to even have, something touch my tongue. Well, at that point, I'm communicating with their physician. Like, hey, we're running into some trouble. The patient is not putting things in their mouth. The physician has typically already prescribed something for them. And it may be something of a magic mouthwash. It may involve lidocaine. There may even be pain medication involved, because they're trying to keep that patient taking things in by mouth, because we know the late-term side effects, if they stop swallowing during their treatment, impact them in their rehabilitation stages post-treatment, okay? So I want to break that down a little bit, because I just gave you a lot of information. At our clinic, we like to see our patients every 2 weeks during their treatment. Maybe that's weeks 1, 3, 5, 7. Maybe that's pre-treatment, week 2, 4, 6. Okay. Then we take a break for about 4 to 6 weeks once they have completed their treatment, and we see them back. Okay. But anywhere from weeks 4 through 7, my role is to help manage the acute side effects that are undergoing, that patient is undergoing during their radiation. My role is not rehabilitative, okay? This patient is still fighting cancer. My role is to encourage them, keep showing up to your radiation. You have to follow through with your physician's recommendations. And I need you to try to keep swallowing. So here comes that magic idea of, do I need a feeding tube again? We don't know. Maybe they do. It really depends on their weight loss. It depends on if they're drinking Ensures, Boost, or some other form of a supplement, anything the dietitian has recommended. So really that's specific to each patient, okay? Now, again, I am going to assess the functionality of their swallowing. And typically at this point, I'm not seeing, so I'm here, I'm in week 4 through week 7 of treatment, okay? I'm not seeing typically at this point, quote unquote, lymphedema. All right, that's important to understand, okay? This particular patient did not undergo surgical removal of any lymph nodes. So this is our 76-year-old base of tongue, right-sided, levels 2A, 1B, and that patient didn't undergo a neck dissection by their surgeon, okay? So there's no edema or lymphedema, okay? Now I am still saying those words to my patient because I anticipate this is going to be something in the future. I'm saying like, oh, I don't see any side effects so far. There's no lymphedema. We're going to monitor you closely. But I keep saying the word lymphedema over and over and over because guess what happens 6 weeks post-treatment? Maybe even 12 weeks post-treatment. Ring, ring, ring. Lauren, I know I told you I didn't need you because I can speak and I can swallow, but now there's this swelling in my throat and I don't know where it came from, and my eyes are swelling and my cheek is swelling. Okay, remember that word? Hey, patient, remember that word lymphedema? That's what we were talking about. So come on back in and let's get you started on some exercises, right? So you're always kind of one step ahead of your patient. You're always anticipating their biggest fears. You're always talking them through what's normal because they're still scared and fighting cancer. Now, what exercises can I do for my patient during this time? Well, the truth is I can't do a ton of them. They have to do their exercises, right? But remember that booklet I told you about that they received during their first counseling session with us? In that booklet are a series of exercises. Those exercises are based on the Faringo size as well, which is literature by Dr. Paula Sullivan. Those exercises are based on very similar principles that are followed at MD Anderson, with closely following the evidence-based practice for Dr. Kate Hutchison. So as a speech pathologist, you put together exercises that the scientist speech pathologists have done. Now we're pulling it into the clinic. And those exercises may involve something that we call an effortful swallow. Now, if you're a patient watching this video, this is very easy. Okay, remember, I'm creating 3 videos today. This is my second one, and the first 5 goes, I knocked over everything and spilled my coffee, but let's practice an effortful swallow. So I take a sip of something and I swallow hard. I squeeze the muscles of my swallowing. That's what I'm doing. I take a sip of something and I swallow hard. Okay? When I'm completing that effortful swallow, The literature tells us I'm contracting the muscles that are utilized to push food and liquid through the throat. I need to load those muscles. I need to utilize them the best I can. So that is one exercise, an effortful swallow. That is an easy exercise that I gain beautiful compliance in my patients with that specific exercise. Why? Well, they understand that I need them to keep drinking during this process. Okay? They understand that. So my patients are doing their effortful swallow during this process. They may be drinking water, they may be drinking Boost, but when they take a sip, they swallow hard. I also encourage them to do it with their saliva, okay? The effortful swallow is a strategy that is utilized from the start of treatment in your head and neck cancer patient, during their treatment, as well as post-treatment. Because what do you think happens post-treatment? Food sticks in the pharynx, okay? So post-treatment, I need you to continue kind of this idea of the exercise. If you've introduced it week 1, week 2, your patient is a professional at it at this point, all right? So let's just sort of recap the goal of this patient. 76-year-old came in. They are in weeks 4 to 7 of their radiation and their chemo treatment. They have seen me. This is now their hopefully their 3rd visit, to be honest, but maybe it's only their 2nd visit with me. I review with them the importance of the effortful swallow as one of the exercises. There are several exercises. I review with them that you absolutely have to keep using your muscles. You have to keep drinking. You have to keep trying to eat. And I review with them during this time, listen to your doctor. If your doctor told you to take some pain medicine to help you swallow, take the stinking pain medicine to help you swallow, okay? I tell them and remind them that this is not a forever thing. What you're experiencing right now is not a forever thing, okay? So that's really, really important for me as a therapist to tell them. Because remember, our role is hope, encouragement, but yet reality. So stay honest with your patients, but also always provide the light at the end of the tunnel, okay? That's very important in one of my beliefs as a clinician. Now, just to remind you, because I think it's very important, we're still saying the word lymphedema. We don't see any at this point. You're looking good. The literature tells us we shouldn't see any lymphedema at this point. We're not doing manual lymph drainage at this point, okay, because we're not touching their skin and irritating it. We are not working inside their mouth at this point. You're not trying to irritate and spread infection or mucositis. You have to know that. Do not put your fingers in your patient's mouth weeks 4 to 7 if you're seeing issues inside the oral cavity, okay? It's contraindicated, and it's one of the best ways to tick off your radiation oncologist. Now, I don't make these recommendations because I didn't make mistakes, right? I can remember being an overambitious and excited speech pathologist and starting one of my oral tumors on stretching during treatment. Did I tick off the radiation oncologist and the patient? Why? I didn't have a solid understanding of what was my role at what time of treatment. I didn't have a solid understanding of what I had learned about trismus. I didn't have a solid understanding of what my mentor was teaching me with the side effects, okay? So very, very important that before you start to jump into something, you don't make the same mistakes that I did. They're not detrimental mistakes, but they are mistakes and they don't need to be made, okay? So I also think it's important to understand that as speech pathologists, sometimes we mean to help, but we can do more harm. And for me, that patient really was a learning curve in my growth as a clinician. Never did I make that mistake again. Never, ever did I think that I knew more than what my patient was telling me again, because at that moment I wasn't listening to them, right? I just was going, oh my gosh, their mouth opening is, 30 millimeters. I have to do something about this. No, you don't. They're in weeks 4 to 7 of treatment, and you need to stay consistent with your team. Okay. So I think that hopefully what you've learned in this podcast is, based on the timing of your patient's treatment, your role is different. Based on the acute side effects of your patient's treatment, your role is different. All right. The other thing I want to recap on is lymph node involvement. Submandibular drains, follow my highway. My highway of submandibular, lower eyelid, nose, cheek, upper lower lip, lateral chin. Okay. So I hope you learned something in this session. Join me for the next one.